The opinions expressed by the contributors are not necessarily those of FAMS or endorsed by FAMS, but it might be. But that's our legal requirement here. So we are the Funeral Advisory Memorial Society. Most of you are members, but some of you are maybe friends of members. And what we are doing is basically we are not arranging funerals for you. We are a consumers' rights society and a movement also for some advocacy if we have a chance. One of our feats that we have accomplished is that now funeral homes have to have by law itemized price list of services they are giving, so that you're not faced with just a package that that contain things that you don't want. So you can you have now the right to pick and choose what you need, and there's some essential things that you need, but you have the right to make some choices there, and that is what we basically accomplished. One of the things, and that is well, about 10 or so years ago, that it is law in Ontario. So the Funeral Advisory Memorial Society, or FAMS, is covering the whole of Ontario except for Northern Memorial Society, which is dormant at the moment, and we might be able to merge with them. A lot of societies came together into FAMS because in all big towns we had a memorial society, like in London and Thunder Bay and Kitchener, Hamilton, Peterborough, Ottawa, Toronto, of course, and Niagara area, and there was one in Guelph, but they went dormant also, so we have not been able to merge with them because they didn't exist anymore. However, so now we are one organization, and what do? We are giving our members tools to plan their end-of-life situation, and advise that they give it to somebody that is close to them, because in most cases the will be read after the funeral or the cremation. And we also give you the advice that what we found is that basically a funeral should not cost more than about $3,000. If you want to spend a lot of money on headstones and expensive urns and so forth, that is of course your choice. If you want to spend, say, $10,000 to $30,000, that is fine, but the point is that you don't need to. And that is very important. It can even be transfer service of cremation of the body, and then cremation for under $2,000. That is even possible. So we are giving you the tools for planning, and it's your responsibility to have it with somebody that you trust. If you don't have anybody, then a lawyer or a notary would be a good move to have it with. What can I say further? We have our we try to update our members for all the things that are happening, and doing these webinars are one of the things, newsletters and online meetings like these. So that is basically what we're trying to do. We are totally a volunteer organization. We don't have staff, but we do have expenses because our website is not just a website, it is a whole consumers management system that is automating payments and so forth, and database and newsletters. It gives us all kinds of tools to do things, but it is quite an expensive operation. For now, we can still afford it, but eventually we might have to look at another solution. So that is basically, in a nutshell, what we are doing. And we are also speaking to places like retirement homes or other groups about FAMS and what you can do in planning. So that's basically it. Okay. Of course, bells are ringing. It shows how, if you're not muted, that happens. Anyway, without any ado, and if you have any questions, you can always write us or phone us, and we have the resources at the end of the session. So today we are welcoming Dr. Dirk Huyer, Chief Coroner for Ontario. And for our next FAMS meeting, it will likely be in February or January if you would prefer, then let us know. Topic still has to be determined, and what would you like to hear about? Maybe at the question and answer or speak now, that's fine too. But if you want to let us know, email info@fams.ca. That is our email address. And today's team of co-hosts are members of the FAMS board. And if you want to be part of this wonderful team, again, contact info@fams.ca. So if there are no other questions or suggestions, I will now start with the land acknowledgement. We respectfully recognize and acknowledge the relationship that First Nations, Inuit, and Métis across Canada have with the land all Canadians live on and enjoy. This acknowledgement should only be a first step in eventually approaching restoring unceded land to the Indigenous nation or nations that previously had sovereignty over these lands. So with that, I would really like to welcome our speaker for today, Dr. Huyer, Chief Coroner for Ontario. And Dr. Huyer, appointed in March 2014 as Chief Coroner, has been an Ontario coroner since 1992, serving as a regional supervising coroner for various regions. With over 5,000 investigations, he specializes in child maltreatment, collaborating with the SCAN program at the Hospital for Sick Children. In 2015, alongside Chief Forensic Pathologist Dr. Michael Polanen, Dr. Huyer led the development of Ontario's first unified strategic plan for the death investigation system. This plan prioritized high-quality, culturally responsive services, emphasizing engagement with Indigenous communities. Driven by a commitment to address deaths at Indian residential schools, Dr. Huyer initiated a community-directed approach. He established a team to assist in understanding the fate of those who didn't return home and implemented a province-wide initiative for unmarked burials, fostering transparency and accountability. So there will be time for questions after the presentation, and take it away, Dr. Huyer.
Thank you very much. I'm going to attempt to screen share. Just get this screen share. So thank you, and good afternoon, everybody. Thank you for the land acknowledgement. I was going to do that, but I appreciate that, recognizing that I'm a settler on this great land that the Indigenous peoples call Turtle Island. I'm on a journey of learning and a journey of understanding all kinds of perspectives and the history of the nation as it is now known as Canada, and the lands that we are residing on. So I understand that this presentation came from an ask for an information session and asked about what does the Office of the Chief Coroner do, and where this unknown sort of organization. So we brought me to the table, and here I am to talk, and I'll be more than willing to have lots of time for questions. I applaud the work that you're doing. It's great that there are organizations and groups such as yours that allows people to navigate what is a very challenging time, either before death or when families are responding to after death. So in the presentation, I do want to start off by acknowledging that while I talk about numbers of cases, we talk about numbers of deaths, we talk about investigations, it's so important that we don't forget that those are all people that passed, people who died often tragically, and people who were loved by their families, friends, communities. And at times we will depersonalize things in our world because it's our clinical way of potentially managing the challenges. It sounds like a bit of a cop-out when I say that, but the reality is that's what I observe and that's what I see. And so by no means are we forgetting the loss that people have suffered in the conversations that I'm going to have today. So just going to give you a quick overview of the work that we do and how we come to this and what's the structure in the organization. The picture that you can see on the slide is a building called the Forensic Services and Coroners Complex. And if you ever drive on 401 and you pass Keel Street, you'll see a big hospital on the north side. And right across the hospital, there's our building, which has what looks like a number of mushrooms on the top of it. And it is really an incredible facility that allows us to help to do the work that we can in the best possible way. It was opened in 2013 and transitioned to that location from downtown Toronto. And it was built both to recognize the significance of death investigation in Ontario, but also built in the 400 series highways with the capacity that we have to be available to respond to a mass fatality if necessary, which we hope we don't ever have to, but certainly is something that can occur. The Office of Chief Coroner functions under the Coroners Act, which is a piece of legislation in Ontario, which provides us the authority to undertake the work that we do. As the Chief Coroner, I have responsibility for administering the Act. So all the death investigation services in Ontario fall under that authority and fall under my responsibility. I have 3 deputy chief coroners that I can delegate my responsibilities to when necessary if I'm away, and they also have a variety of tasks. And then the province is divided into a number of regions where there are regional supervising coroners. All of us are physicians, and each of the regional coroners has responsibility for all the death investigations within their region. And the regions are roughly divided by by population and therefore number of deaths, but some of them are divided based upon geographic and complexities. So for example, the regional supervising coroner in Thunder Bay would have responsibility for a significantly a smaller number of deaths, but many more complex circumstances with those deaths that occur in First Nations communities that are fly-in or very remote. We have about 320 coroners who are all doctors, and they are working both at a medical practice typically, so they're family doctors, emergency doctors, other doctors who work in hospitals, and they do the coroner's work in addition to their practice. So they will be available and scheduled to be on and available to attend scenes when deaths occur, and they will then be the lead of the investigation and part of the team. So these are essentially what the coroners do is they work together. Any out of hospital situation work together with police. Police bring investigative skill, coroners bring investigative knowledge, but significant medical knowledge. The two will work together to try to answer the questions for the death and help to sort through what needs to be done next. In about half of our investigations, we ask a pathologist who is a doctor who specializes in examination of deceased persons and also a specialist in understanding disease. to complete a post-mortem examination, otherwise known as an autopsy. And the pathologists will do the extent of examination and the additional testings that they feel is necessary to answer the questions most effectively as to why the person died. We have two types of pathologists. The anatomic pathologists are the ones that typically work in the hospital, and they'll do other work in hospitals, such as the laboratory work, the biopsies from surgery or other samples that are taken to look for disease and cancer and things like that. And then forensic pathologists are anatomic pathologists who do an additional year of training and examinations to be the pathologists who will do the more complex and the criminally suspicious death investigations. So the homicides and other cases where there's concerns about potential criminality. And the forensic part is translating the medicine into the legal forum. So understanding it from a medical legal point of view. So they will be the ones who testify in court, and they will be the ones that work directly with the police to help to sort through what might have happened and who might have, the police then are informed on how to figure out who might have done the work. All of our investigations are teamwork. There's a coroner, pathologist, typically police, but there might be other investigators like Ministry of Labor when it's a construction site or an occupational injury, the SIU when it might be a police-related death. We have other investigators, fire marshal that might be involved, Children's Aid Society when it's a child death. So there's all different members of the team that will participate in doing the investigation. Approximately 105,000 people pass per year in Ontario, and we're involved in about 21,000. And we're involved, and I'll get to this in the next slide, but we're involved when something unexpected happens, something tragic. Nobody expected that person to pass. They don't have typically health trajectory towards death at that particular point, and or they're from a violent or a non-natural event. By the end of our investigation, because many of those early unexpected ones turn out to be through investigation sudden cardiac events, which is natural. About just over half would be a natural, about 35% would be an accident. And I'll go into the details of what that means. About 9% suicide. 1% we can't figure it out, and I'll tell you that a little bit more. And only about 200 to 300 homicides per year in Ontario, which those are the ones you hear about in the media most commonly. And so if you feel that we're busy when you hear about homicides, you can imagine how busy we are, given that that's a small proportion of our work, but a very important, all of our work's important, but very important area of the work that we have. About just over half, I said half earlier, but about just over half will proceed to autopsies. And of those, about 7,000 of those occur in Toronto. So it's a very busy facility, a very busy organization. Now, those are the cases we investigate. We also review and evaluate all long-term care home deaths, but we don't investigate all of those, but we have reports of those, and we have an electronic reporting process that acts as a screening tool to determine if investigation needs to occur, and allows us to review each of those at the level of, we have registered nurses who are working specifically and look at each of those death reports. And then about 4,000, this year will be about 4,500 people who have chosen to die from medical assistance in dying. They are all reviewed by a team of nurses that work directly with me. So in fact, we're involved in about 45,000 of the deaths that occur in Ontario in some way or another. So it's a very busy area of practice, a very important area of practice, and we would be deemed one, if not the biggest death investigation system in North America, because they're all focused on, in Ontario, we're provincial, so we have the 15 to 16 million people in Ontario. In the States, they're all county-based. So LA and New York County, they get close, but not quite the same population. So we see a lot of tragedy and have a view in a lot of different and unusual things. So as I said, what we do is we're involved to investigate deaths, and many of the categories are how. So people who died in ways that we didn't think they should. So something non-natural, drugs, opioids, harm, car crashes, violence, and then the other ones which are sudden, unexpected, and we don't know exactly what's happening. We need to figure that out. Some are rare, so deaths in correctional facilities, deaths in group homes that are funded by developmental services organizations, deaths in psychiatric facilities. All of those deaths are investigated, even when we know that they're natural, because these are locations where people may not have been able to speak and advocate for their own care because of various challenges. And so we will investigate all of those. And then sometimes we'll investigate when there's concerns for other reasons. And so it's really fairly open to when we can investigate, but still we need to follow within the legislation because of the fact that there's so much authority that comes with the work that we do. We want to be sure that we're respectfully recognizing the power and duties that we have. So what do we do? Well, the front part or the initial part, it's to answer questions. It's to answer questions for the family, to answer questions for the community, answer questions for the police and other investigators. How much we share with the families, we can share everything. Others, it's limited on what we can share based upon privacy and protection of information sharing. But really, it's who died, when they died, where, what's the medical cause, and then we classify, which I'm going to talk about in a minute. And giving those 5 answers helps to really understand this, or it gives the outcome of the circumstances and the trajectory to how that death might have occurred. The second part is thinking about anything we can identify within the circumstances of the death that might lead to a recommendation to an organization or some place that would have the ability to potentially change something to help to inform the prevention of further deaths. So we answer what happened, the best of our ability, and then we say, is there something we can learn from that to make things better and try to stop that from happening again? And the other thing that we may do is an inquest. An inquest is a hearing before a presiding officer. We do those infrequently. This year we'll approximately do about 60, where compared to the 21,000 deaths per year. So they're not common because we can make recommendations all the way through the death investigation from the coroner all the way through to myself. And we get information from a variety of sources. It might be from the neighbors, the family, the medical records, the employer, other doctors, emergency service workers, other investigators. So we really have the ability to get any information we need related to the deceased person and where they were. We can go into where they were, full authority. We can get all the records, all information related to that person. And so that's where we have fairly broad-reaching powers. So just to summarize, you can see non-natural deaths, which would be car crashes, suicides, any homicides, and then sometimes when we don't really understand what's happening. And then the specific natural deaths where they typically are vulnerable populations, which I've talked about. And the one I didn't mention earlier is anyone who dies during pregnancy or within a year after pregnancy. We will investigate those because of, again, focused on the healthcare of those who are pregnant and the importance of that as a health area of scrutiny. So in our powers, we have the sole jurisdiction over the deceased person. So we actually complete a document called a warrant to take possession of the body. And that means that we without our direction, there can't be any movement, there can't be any alteration of the deceased person, so that we can see everything as it was when the death occurred. And that allows us to help answer questions. So for example, in the hospital, the doctors may have, or the nurses may have put in intravenously or put a tube in their mouth. Well, those stay in until we take a look because they may not have gone into the right place, or the punctures where the intravenous went may be confused as to whether somebody else might have put that puncture in as opposed to a healthcare professional. So we want to see those catheters, know and get an understanding of where they might have come from, and also to understand what the healthcare folks put as far as treatment goes. We conduct investigations. We have the authority to ask the police to assist us, not for criminal purposes, but for the purposes of our work. As I said, we can enter and inspect anywhere, we can seize information, and we can mandate an examination if in fact we believe that it's important. Having said that, we're very we very much make every effort to communicate with families prior to any examination, and it allows the opportunity for families to express their concerns and potential ways that they wish for things to be accommodated. And we can do the extent of postmortem examination in Toronto is variable as far as how much dissection we do, because we have a CAT scan machine and we CAT scan every body, which may allow us to do much less opening of the body. And in fact, the majority of examinations completed in Toronto are not full autopsies in the traditional way. And the other things that we also do is anybody who's cremated in Ontario, and that's about 80,000 people per year now, and anyone that's shipped out of the province, a coroner must have the final authority for that to ensure that we're not missing or losing in any situations where there should be investigations. So I'm just going to quickly run through the characterization of the death. So we have a natural death. Sorry, the manner is, which is what I'm going to talk about, is the characterization of the event that led to the death. And why is that important? Well, it's important from an insurance perspective, because an accidental death may provide double money for things, lawsuits, and public health generally. Trying to inform changes by population health is an important way to look at things. And just quickly going through the manners of death. Natural is when it's a disease or something to do with that disease, if people are being assessed, treated, or the diagnosis was occurring. There was no injury involvement. Accident is when the injury occurs and death wasn't expected. So something untoward happened, but the person wasn't intending, or another person wasn't intending to contribute to the death. Suicide and homicide is when there's intentional injury. Suicide is when that intentional injury is from the deceased person, and homicide is when it's someone else. Undetermined is when we can't figure out between those different categories. An example would be when we find skeletal remains in a forest, and we don't have any tissue or anything abnormal on the bones that shows any marks of injury. So we don't know how they died. They could have died any of those four ways: naturally, from a heart attack, accident, from drug toxicity, suicide, from another harm, and then someone could have caused their death, and we wouldn't be able to determine that. So that would be an undetermined death. I'm going to just shoot through these. I will share the slides, and I don't know if you could post them along with the YouTube. I'm not sure if you can, but I'll briefly put them up so those on YouTube can pause when they want to look at them. But it's what I've talked about right now. Just the summary was already provided. And how do we decide? Well, we do that on the balance of probabilities, but it's based on careful scrutiny of the information that's present to us. And the information leaning one way needs to be clear, so it needs to be understandable, and there really needs to be a link between the cause, the evidence, and the manner of death. So a natural disease has to say there is no injury involvement whatsoever, and that clearly there is a natural disease, and the two came together and makes good sense. Convincing, so it's really got to be reliable. So a car crash, having a video showing that would be very convincing. Cogent is when it all sort of would be open to question, and all of the questions are answered. There isn't anything that takes you off track when thinking about this. So these are the approaches that we take, and it is on a balance of probabilities because there's no finding of fault by us. It's all about learning. It's all about bringing things together. So if it's more likely accident than suicide, we would side on the portion of accident. And the two are very close, and you can't really decide. That's where we would get to undetermined. That's homicide I've talked about. There's no fault, which I've talked about already. And that's the undetermined, which I've spent some time on. The cremation certificates, just as a little bit of expansion on what I talked about. Our death investigations generally, historically, has been really to understand surveillance of death and also registration. That's death certification generally. And ours then flowed out of homicides or misadventure, and even further it flowed over the years into one that drives policy about public safety. So we're a public safety organization, and really to try to help make a difference to improve death, or systems to prevent death. So what we do in a cremation certificate is we review the circumstances, generally based upon the medical certificate of death, but we also have other ways to obtain information by talking to who the certifier was, and if needed, we will do an investigation. It also provides an opportunity. We hear from families and funeral homes when concerns that weren't brought up during the time around death or didn't come to our attention may come to our attention, and then we would open an investigation. Now, that's a small number of situations, but still, it's a notable opportunity for us to ensure that there is been consideration of an investigation in, as I say, 80,000 of the deaths that occur within the province. And this is the legislation that it falls under. Alan talked about the price listing, which also falls under similar legislation of the Funeral, Burial, and Cremation Services Act. And this is the same place that cremation certificates are. I'm looking at the time on, and I can talk a little bit about some of the areas that we practice in, or we can open for questions.
Yeah, please go ahead.
Okay.
You know, if it is 10 minutes more, it's fine.
Sure. So I bring this forward because, number one, it's a very significant issue that's occurring in ongoing tragedy of deaths that occur within the province and across North America, to be honest, which is substance-related deaths. And it also shows you the kind of work that we do and an outcome of the work that we do. But we investigate different types of deaths in different ways. And so we have an approach to, for example, opioid-related deaths, where all substance-related deaths, so substance being opioids being one substance, alcohol, cocaine, methamphetamine, those are all substances. And it is one of the most significant causes of death in Ontario. It's almost 2.5% of all deaths in Ontario occur from substance-related harm. And they have continued, this has continued to increase over the years, starting in 2023, and I'll show you some numbers. And so what we do is we have a specific set of questions that helps guide the investigation, but also leads to the collection of the same information from each of the deaths, which we can then take together and aggregate so that we can see the trends that occur over a number of deaths over time. And this illustrates the quarterly reporting. So we report this information, and we share this information with those who are in a position to make change. So all the public health units across Ontario, those who are in harm reduction, those who are in treatment, all receive this information to inform the work that they do. Because our job is death investigation. I wish sometimes I had the job of overseeing the healthcare system to try and make a difference, because it's frustrating and it's sad when we continue to see these deaths occurring on a regular basis. And as you can see in the bottom circles, 7 people in Ontario per day, on average, are dying because of substance-related harm or opioid-related harm. I mean, that's a tremendous number of deaths that are occurring. And you can see about a third of the way along in the graph, their arrow down is where just in 2019, the numbers had started to decrease. And Alan, I can't mute, so you're going to hear the siren going by. You can see the pandemic started just after after 2019, and the numbers just increased by about 70% during that period of time, likely because services were withdrawn, people were by themselves, so there wasn't anybody with them when they might have had a toxicity event, and the shelters were moved into hotels. So as opposed to living congregately with a number of people, they were by themselves, so it enhanced further independence of use, and therefore less people present to be able to intervene. This is showing year over year, and it's remarkable. Starting in 2003 and until around 2010, 2011, much of this was prescription and pharmaceutical opioids with others that were purchased outside. But now the majority of the deaths are related to non-pharmaceutical, so things like fentanyl, which is not prescribed and not purchased through healthcare systems. It's made by labs illicitly. And our numbers, which is a rate, it's more than double in 2021 compared to 2017. We have seen a little bit of a decrease in the first 2 quarters of this year, so the first 6 months of 2023, but still, while we've seen a little decrease, it's still substantially higher than 2019. So there is a lot of tragedy. And you can see that number is 2,500 people passed last year in Ontario. Ages, the majority are about 75% are between 30 and 59. So this is a very young series of people who die. So the life years lost is tremendous, and it's a preventable, not necessarily easily preventable, but the illness, the cause itself. So drugs into the body, no drugs into the body, then they wouldn't die. Recognizing it's very complex on how and why and what was taken. I'm not trying to oversimplify, but it's not something that is not preventable. And it really shows you in BC, the life expectancy has flattened overall. And in the US, there's a number of states where life expectancy has gone down related to opioid deaths and the number of them that are occurring. This is a sex, about 75% are males compared to females, and that's been ongoing since 2019. We did have a decrease of both in 2019, but then steady increase, and as I say, about 75%. These are the substances. You see 85.6% are fentanyl or other substances similar to fentanyl, and we continue to see different and new substances coming into the supply, leading to different deaths. You can also see now down in the bottom part of the graph, the total stimulants. About 68% of opioid deaths have a stimulant, cocaine or methamphetamine, also associated at the time of death. And this, I'm not going to spend time on this. I'm going to leave it on for the YouTube just for a minute if you want to look at it later. Furofentanyl is an analog. What we see is in 2022, so it speaks to the number of new substances that come in that are unknown danger, unknown toxicity, except know that they are strong. There's only 1.2% of the time did we find it in 2022, and now in first 3 months of this year, we found it in 14%. So it speaks to the ever-changing supply and the fact that, frankly, we don't know exactly how toxic they are, because these are substances that aren't known pharmaceutically, so they're not tested in people. There isn't human studies, so it's unpredictable about how toxic they are. And these are other substances. So in about 60% of the case, we're seeing benzodiazepines, which are not opioid substances. They're like Valium, you might have heard of, or Ativan. They're calming substances, but they're of a different class. So one of the responses to an opioid toxicity event when someone collapses is to give naloxone. You've probably heard of that, Narcan. Well, it works for the opioids, but it doesn't do anything for the benzodiazepines because it's 2 different types of drugs. So the 2 will work together synergistically to make the person more sedated. But the naloxone won't work on the benzodiazepine, but will work on the opioid. So it also makes the response at the immediate time more difficult. And cocaine will not be impacted either by the use of naloxone, and we see it in about half. And I'm not directly knowing what's occurring and why people take both, but there is discussion that with the danger of fentanyl and the sedation with it, that cocaine is being taken to keep people more alert, to balance off the sedating effects with the stimulant effects of the cocaine. And so that people likely, as I understand, are taking both substances on purpose. Tragic is even more tragic in some other locations. This is the rate per 100,000 in Ontario, 17.5. But looking at locations such as Peterborough, Timmins, Thunder Bay, they're all over 80. And so while it's in Peterborough, 19 deaths in the first quarter of this year, that's a substantial number compared to their population. And 23 in Thunder Bay, again, terrible, terrible tragedy that we see in a variety of locations. And it's unclear exactly why in those circumstances. Services likely the determinants of health and the supply in all of those different areas likely. So I'm going to leave that on for a second for the YouTube. And then my last little section is just medical assistance in dying. That all of those deaths are reported to us, and we review for the purpose of reporting. So we make sure that we report systematically for public awareness and public transparency about medical assistance in dying. We monitor for compliance with legislation and for compliance with regulatory approaches, and we provide oversight. So if we do see something of concern, we share that concern with those who who provided from an education point of view, and then of significant concern to the regulatory bodies. And then we collect data and help to have an understanding of what's occurring in MAID in Ontario. Number of deaths in MAID, around 4,500 this year is anticipated. This is an old slide. Will be around 3% of the number of deaths are from medical assistance in dying now, which is similar to many of the European countries that have medical assistance in dying for a number of years. So Belgium and the Netherlands, for example. As we continue to see an increase year on year, it's about 20 to 30% increased numbers per year. And as I say, there's a team of nurses that work, well, I work with them, and they have specific expertise and competencies to evaluate all of these deaths. So my last slide I'll stop on now is just gives you the view. It's about half and half, men and women, and cancer is about 62%, and cardiac and lungs like emphysema or heart failure, and then neurodegenerative is things like ALS. The average range is about 76 years old, and about half are in a private residence, and then 40% to hospitals and then other settings. So I think on that note, I'm going to stop sharing, and hopefully, Ellen, that covered a number of things that you were looking for.
Yes, that was a great presentation, very informative. So now I will thank you very much for this. Now I will entertain questions. Okay, we see Pat Cleland. Go ahead, Pat.
Yeah, you were mentioning the fentanyl plus cocaine. There's an old thing called a speedball. It was heroin plus cocaine, and they always believed that it would settle them down and they were less likely to die. I used to work for the Addiction Research Foundation. That's why I know this stuff. And so it looks like it's simply carried over into a new opioid. It just...
Yeah, I don't think it carried over. I think, Pat, that there was such recognition. Hopefully, okay, I'm calling you Pat. There was recognition of the danger of the speedball. And the speedball was also, as you know, given at times by others. But I think there has been a number of years where we were not seeing the stimulants. And so now I think you're absolutely right, though, that we're returning to a similar setting and a similar rationale for it. As you just comment, where you're saying heroin is not very available nowadays.
No.
And fentanyl is the drug of choice that many have, because people who use drugs, as I understand, know that fentanyl, what the safety is for them individually, and they've developed tolerance to fentanyl, and it's probably felt to be safer than some of the others in their own minds, although extremely risky and dangerous at times. Yeah, thanks, Pat.
Thank you. Then Janine has a question.
I just wondered, that very last slide in your presentation, you didn't really put up. It was just there for a fleeting second, and I'd really like to see it. Would you be able to put that back on and just talk to that last slide, please?
You mean the one that says questions? I'm just teasing, Janine. I'm just teasing. Yeah, it was, let me just share it into the slideshow so you can see it better. It was really giving a bit of a view of the work that MAID does. So it's what I essentially talked about. So our approach to MAID reporting or medical assistance in dying is we really try to have a balanced approach of making sure that we do effective reporting, monitoring, and oversight, but also recognize that we don't want to be too intrusive with families and clinicians, but we need to do our job to be able to do it as effectively as we can. And so in doing that, I made a decision to bring together a team of centralized, and their nurses all appointed under the Coroners Act with the same powers and duties as a coroner, to learn about the topic, bring their diverse, different clinical experience. They're all clinical nurses who have worked in the healthcare sector together, and develop a good understanding so that the providers and the families have people who are understanding the approach, thinking about this, and watching for trends and themes over time. So we really need to do things a little bit differently than coroners work, because the coroner typically is trying to prevent deaths. These are deaths that aren't to be prevented because there's a choice of people dying, but we want to improve the system or inform improvements of the system. So it's a different approach. It's not one that typically would fall under the Coroners Act, but the legislature decided that that was something in Ontario that we would do, and we have the most systematic and the most we have the most oversight than anywhere in the province or provinces except for Quebec. Quebec would be similar to us, but nowhere else do we have the oversight that we have in Ontario. But we also report. So Health Canada has a legislation that says that providers who are involved with MAID must report certain pieces of information to Health Canada for reporting across the country. We do that. We collect that information and report for the providers so that they don't have to do that work twice. So that's essentially what that slide is showing.
Thank you very much. Then we have Herta.
Yes, can you hear me?
Yes.
Yes. I wonder if death in nursing homes get reported properly. My husband died about 14 years ago. He was 94 and he only spent about 3 months in a nursing home. And he ended up with constipation so badly that his intestine burst. He was 3 days in the hospital, and then he was sent back on the 3rd day to the nursing home, and he died 3 hours after being sent back. And then when I got the death certificate, you think, well, he's 94 and all that. The death certificate didn't say what he died of, so I called the funeral home, and they said, oh, the death certificate says Alzheimer's, high blood pressure, and prostate cancer. It did not say that he died of a burst intestine. And I'm sure the doctor was notified from the hospital why he, what he had.
Yeah, thank you for sharing that, and sorry for that tough time for yourself, but most importantly for your spouse, because that's not a very, it's very tough. A lot of pain, a lot of medical intervention, and I will say
they didn't intervene because he was 94.
Well, he was still in hospital and he was still struggling, and so and so I can say that 14 years ago we did not do a good job. And there was a public inquiry into the safety and security of long-term care homes held by Justice Galeese in 2017. And our office was subject and focused. That was in response to the Wettlaufer murders. And our office was subject and focus of the inquiry. In fact, we took it we took it where we should be taking it, which we weren't doing as well as we should have. And we've changed our approach to reporting. And our approach to reporting now is we have a mandate responsibility for the registered staff to complete an electronic reporting process that has questions about what you just asked about, Herta, which is what's gone on over the recent past. Is there any concerns that might lead to care related? And it's mandatory that if there are any concerns that we speak to the family now, which we didn't do. And then even after that's reported, a registered nurse from our office looks at that. And so I think we've changed. I can't say it's perfect, but we've changed substantially, and we're doing a lot more investigations. There's about We did 1,500 reviews and 700 investigations since March. And that's probably about double what we were doing before. So we have opened up, we've got an expert-informed approach to reporting now, which we didn't have. We have a review of those reports, and we have a lower threshold for opening up the investigations. So I think you're right, is the answer. And I'm sorry that we weren't doing as well back then.
Thank you.
I would like to add on to this, basically, what would happen if you would have determined this was happening there?
Which one? If what happened to Herta's spouse?
What would happen if you would have investigated and you would have noticed what was happening? What consequences would be there?
Yeah, so consequences, we don't have consequences, but what likely would have happened is that we have an expert review committee as well for the long-term care and geriatric review committee. But I think based upon Herta's information, the coroner would have likely identified that constipation was the underlying reason all of that happened, and would look backwards to say, okay, what did the home not see to miss the constipation, or what did they give to cause the constipation by medication or by the approach that they took for general care. And recommendations can then be made to the home for changing their practice, but also can be made more broadly to the healthcare, the long-term care home sector. So that's the kind of approach that we would take with that. There also is now a compliancy investigation approach within the Long-Term Care Act, and this is the type of thing that would go to the investigators to see if the care aligned with the legislation and the approach that should occur. So there would be two different avenues. We would look for the learning opportunity, and the investigators would look at, is there a compliance issue? So that's the approach that would be followed likely today.
So what would happen if there is, for instance, a pattern of the same kind of thing occurring? What would be the next step?
Yeah, that would, I can't speak for the compliancy officers, but they can take away the funding and take away the beds and the license within the facilities if there isn't the approach.
Right, thank you very much. Judith, I guess you have some people from the chat.
I have 4 questions, 2 from the five questions, 3 from the chat and 2 of my own. Starting with the ones from the chat, have any LIDAR, is that how you pronounce it? LIDAR, anomalies at former residential schools been confirmed as human burials?
Yeah, LIDAR, so there's a number of ways for residential schools, or a number of ways of looking for burials. And one is ground penetrating radar, which is, it's like an ultrasound kind of thing, or it's like sending waves down into the place below, and the waves bounce off things in different ways. And as you now analyze those, you might see an anomaly. Initially, it was developed for pipes, finding pipes and other things, but it's one thing. LIDAR is one from above, and and again can show anomalies in the soil and approaches where they're believed to be burials. And at this point, those tools have been used by nations and by communities and supported by experts to provide perspective as to whether there may be burials. Now, if you're in a cemetery or a known burial location and there's a number of grave shafts, so if they're systematically placed, you can pretty much assure, because the anomalies are systematic and are in a row and are consistent with a rectangle, you can pretty much be assured those are grave shafts if in fact the information is such that this was likely a burial location. So there has not been disinterment or digging in those particular areas. So it depends on the extent of verification. The location, so to Kamloops, which is the 215 in BC, I can't speak too much about those, but I can speak about a couple of Ontario locations that have identified, and the communities, based upon the oral information and the investigative findings and the LIDAR and GPR findings, it's their belief that those are unmarked burials, and it's really challenging for many communities and nations do not want to disturb those burials because it disturbs the spirit and the journey of the spirit. So they are presumed to be and accepted as to allow commemoration and recognition and protection. So it's a long answer to your question. We haven't, the simple answer is there hasn't been scientific digging to say that those are bones and to confirm it. We can't see bodies on LIDAR or GPR. We see changes in the soil. But based upon information, based upon records, based upon those tools, there are areas that there isn't much question in my mind, and definitely not question in many other people's minds, that those are burial locations.
Okay. Someone says it's very impressive, your efforts in Ontario, and wonders how the other provinces are doing.
Well, I thank you for that, and hopefully I don't look for impression, but we try to do the best impressiveness. We just try to do the best that we can based upon where we are, and try to answer questions in our best way. I would say across the province, or across the country, we're the biggest. We're also the best funded, and probably because of the volume and the inclusion or embedment of forensic pathology in our system, I think that allows us to work together in such a systematic way. I think there's pockets of very good and different areas of very good across the country. So in BC, for example, their relationships with Indigenous communities probably stronger than many others. Their work on drug toxicity is very strong. Their approach to looking for particular areas of death and reviewing those at a death review panel approach is very good. And then as you come across the country, I could give you different examples. I don't think that they all have the capacity and the resources to do what we do. So we're a little blessed with that. And so it's tough to give you specific answer beyond that. I think we all work together. We meet regularly, and we have a secretariat, because it's a provincial jurisdiction, but we have a secretariat that Public Health Agency of Canada has brought together to try and bring us to a common approach for things, so that we can have information and investigative approaches that are similar across the country. So I think that's I know that's a work in progress, but it's really great that Public Health Agency of Canada has stepped in to help us with that, because otherwise we'd meet once a year, we'd all have great ideas, but then we go back to our day-to-day work and we wouldn't be able to bring the coordinated approach that we're trying to do. So again, a long answer to your question.
This one will probably be a short answer. You say that you were involved with bodies that are shipped out of province, and I wonder, does that include someone who chooses to be buried in the cemetery in Gatineau?
Yes. Yeah, we're supposed to, people are not supposed to leave the province without a document completed called a shipment outside the province. And typically, depending if there is a funeral service or a transfer service involved, they will request that through an online process that we have in the province. We do have the capacity for families to individually seek those if the family are doing their own transfers and their own arrangements by calling our office. It may take a day longer or a day too longer over the weekend, but we have a process that recognizes that families can request that themselves, and so we do have that capacity.
In a case like this is another one from the Q&A. In a case like Curtis, is there now any way that a family member could request further investigation or information from an investigation?
Yes, it would depend on when it happened and whether there would be information that would be available for that, but it's a conversation with an investigating coroner or with our office, and we would have a conversation to determine what extent we could learn more or answer questions and whether it is something that would be a circumstance that our office would get involved with.
We keep hearing on the in the news about problems with a shortage of nurses and a shortage of doctors, and people don't have family doctors and all of that. Have you been having trouble recruiting staff?
Yeah, there's a shortage of nurses in acute care settings. So in the hospitals and others, there actually are probably as many nurses licensed as there have been, or more than there ever have been. So from a nursing perspective, we've had substantial success because we're doing something different. And so there have been many applications for our positions. We have 20, 30, we have about 35 nurses working with us. I think it's 35. That might be a little bit high. It's around 30. And we did not have difficulty. Remembering 30 is a small number in the big picture. We are having trouble with physician recruitment because our work can happen at all times of the day and unpredictable and unpredictable based upon geographic. So having someone scheduled and available to take a call and to respond to this at all hours of the day is difficult because physicians have their practices. Otherwise, we don't have substantial number of full-time availability. So, for example, in Powassan or North Bay, for example, North Bay, there would be approximately 1 or 2 people would be dying that would be investigated per year. Having somebody available 24/7 and being able to fund that, unfortunately, we don't have the financial capacity to do that. So we do have difficulties, and it has been a real challenge for us in some areas. So I don't think it's because of physician shortage per se. I think shortage is part of it, but I think it's also because of the type of work, and it requires different consideration and requires people to commit a portion of their time without necessarily having that on-call stipend that you might have otherwise in healthcare. So it is a bit of a difficult time for us.
And just to say thank you very much. I've seen your office at work. I attended an inquest a couple of years ago, and I was very impressed at how smoothly it ran. And the maid death that I was witnessed, and everyone was milling around because they said we can't do anything further till the coroner gives approval. So I thank you very much for all the work that you do.
You're welcome. And we've changed our approach to MAID that doesn't have to happen anymore, because we were doing that just in case we needed to transfer someone for examination, and we realized that we do that rarely. And so we've stopped that milling around and holding off because we felt that was intrusive rather than beneficial. So, but thank you for sharing that.
Great. I see another question from Pat.
Yeah, before I worked at ARF, when I was a student, I was a ward clerk in my local hospital. And I had this vague memory that any death within 24 hours of admission, we had to call the coroner. It's amazing what you remember from long ago. And it was a small city, and the GPs just rotated. So the real question is it Dr. Demers or is it Dr. Purdon who's on now? But am I remembering it right? And do we still have something like that?
Yeah, I smile because it's always been talked about and still remembered. Never was a fact.
Oh,
never
really?
was an actual rule, but everybody did it.
Yeah,
So,
I remember it so clearly.
Exactly.
Oh,
and
that's incredible.
Dr. Purdon is a good person from everything I heard.
Yeah, he was our family doctor for years and years.
Heard very good things about him.
Yeah. And then another question, as a retired civil servant, I'm curious how Ontario ended up doing the coroner stuff on reserve. Because in general, when the Fed's trying to download something on reserve, our response has always been, absolutely not. It's in the Constitution, your bailiwick, you do it. And did you know how we came to do that?
Yeah, there was no option. And the nations, for the most part, the nations have accepted our authority. But they're also, we were and have been a pretty systemically racist organization, not racist individually, but
I know what you mean.
by our practices. And so we just presumed as a part of Ontario. We're just going in there. There wasn't the recognition of sovereignty of the nations. And now I'm spending a fair bit of time working with political and territorial organizations, so Anishinaabeg Nation, Anishinaabe Nation, and other individual nations like Six Nations to develop protocols to support the investigation, and also wanting to change our approach to embed culture into the death investigation earlier. So for those of you who don't know, so impactful that culture in all of our worlds are considered in what happens after death. And in First Nations particularly, the journey of the spirit is significantly interrupted by the processes that we follow, whether that be autopsy or whether that be not allowing a ceremony to occur at the moment of the death. And the rationale has been, well, we don't want to mess that, what I told you earlier, we can't touch the body. Well, we don't want to impact the body in any way and following this strict rule. The reality is, we can make those decisions pretty quickly. And in a homicide situation, nobody is going to object that we don't want to impact the evidence. But we do it carte blanche. We just apply it no matter what. And so working to try to change that have a long way to go, and we've caused harm. And it's not just in First Nations or Indigenous communities. There's other communities as well where we've caused harm, and I'm trying to hear those from First Nations, Inuit, Métis, but also other communities. I met with the Jewish Orthodox community. I've met with many different cultural and communities where there is racialized communities, to hear how we could do things differently. And so we're not there yet. We've got work to do, but we've started that work and we're doing it and trying to make our best efforts to do it. And for example, with First Nations, we don't have coroners with our system, right? Our system's set up that they're doctors doing their practice. So they can't leave to go on to, well, they should, can't is the wrong word. The system doesn't allow them to leave their practices to fly to a First Nation. And so we're in the process of developing a cadre of coroners that we will specifically train and who will have availability the next day to take a flight and to go to the nation to do the work. Now, we won't leave the deceased person in that location if not logical, but it'll provide the opportunity for them to see the scene, to talk to the families, to talk to the nation, to get better understanding. So that's work that's ongoing. We still have a ways to go, but that's something. So Pat, thank you for that question.
There's an interesting BBC program on, now it's changing funeral practices, but I mean, you feed into the funeral practices in the UK, and where neighborhoods used to be all Methodists and you knew how to do things, and all of a sudden all of your clientele is Muslim.
Yeah.
And the learning that people have had to do to be able to handle this wide variety of people that they never expected, plus the other end, the totally secular funerals that don't involve churches and maybe involve motorcycles. And
yeah. Exactly.
Okay, thank you, Pat. Thank you, Dirk. And I have a question, actually, it's from Jim. A practical question. Somebody dies, what do you do? Probably different circumstances, if family, or husband or wife or whatever, but then I would call the doctor, I guess. But what is the first step? You find somebody dead, and what is going to do? What's going to happen?
Yeah, it really depends. If it's something that's anticipated, so the person is at the end stages of their life and there's doctors and nurses and a palliative care plan in place, typically that should have their plans in place. And those plans should be that either the nurse comes or somebody makes a determination of death. Now, anybody can do that. It's actually not that complicated. There's no law that it has to be a healthcare professional. Death is, and in those situations, typically the funeral home would be planned and they would come and transfer into their care. If you came home and somebody was found deceased, 911 almost always gets triggered, and the police, ambulance, and fire will come, and they will then, unless there's a known plan of death, they will then call us. And if somebody has a known disease process like coronary heart disease and they're doing okay, but known to be to have this underlying illness, we have a team of nurses who will take the call, and they will speak to the family. They'll look on the electronic medical records, provincial ones, to see if there's information, call the family doctor, speak to the police, and determine if this makes sense to be a natural death. Then an investigation won't necessarily be needed. Then the nurse will say, you can tell the family and talk with the family, you can carry forward with your plans. There doesn't need to be anything more about a coroner coming or anything else, and then ensure that the person's transferred to the funeral home. That's the most common situation. If all of those things, if there's something concerning out of all that, our central office, the dispatch office, will then call a coroner, and the coroner will attend at the scene in the majority, not always, but sometimes we'll delegate the authority to a police officer over the telephone, and then they will make a decision, will there be an autopsy or not. If there's an autopsy, we'll ask a body transfer service to come to the house and transfer to the location where autopsies are done for examinations. Through that period, there should be conversation with the family prior to the autopsy, after the autopsy, and then after the final results are completely back. That's the anticipated and supposed to be approach. Hope that answers it, Jim. Give me a thumbs up if it did. If you got more to ask, you ask away.
Who's responsible for paying for it?
Oh, yeah,
For all of that?
who is responsible for paying for it, Jim's asking.
All of the stuff that I just talked about, if we do an investigation, we are.
Oh,
You are ultimately, because you're
Yeah,
taxpayers,
Yeah.
but it's out of our coroner's office budget.
Yeah, and how many certificates are required?
The cremation ones?
Well, any death certificate, right?
So the terminology is different. So
Okay.
a medical certificate of death is what the doctor completes at the time of death. And it allows death threat to be registered, but it also contains the medical information that allows health policy development. So there's the legal part and the medical part. So that certificate only goes to the registrar general. You can't copy that, you can't do anything, but the funeral home receives it, and that's called a Form 16, with a Form 15, which is a statement from the family about the demographics. Those two forms, 15 and 16, are taken to the local registrar, which is typically the city. They provide a burial permit. That burial permit allows the burial or cremation to occur, and the funeral home will then provide what's called a proof of death form. And everybody calls those death certificates. And they'll give you about 10 of them. And those are the ones that are taken to banks or to insurance people or to employers. And that's what's used to complete things. If more information is needed, then through the Service Ontario, requesting those documents from the Registrar General will give you what they call death certificates. And they can either be short forms, which you get electronically, or long forms, which actually have the medical cause on them. And those long forms have to come by mail, and there's a fee for those. Those are typically not required for anything except for overseas funeral planning, or if you have estate work, typically they're not needed, but those are all the different angles for the certificates. The cremation certificate is totally separate from all of that, and that is completed by a coroner. And that goes specifically to the crematorium who keeps it. And that the family pays for as part of the funeral funeral arrangements. And the funeral home transfers that payment of $75 directly to the coroner.
What if some of our members will not want to use a funeral home, but want to use a transfer service and a crematorium? How that goes, then the crematorium will issue or deal with that, or?
Yeah, the crematorium has the ability to ask for a coroner certificate. Families can individually ask those as well. They call our office. It's on our website, the numbers to call. That takes sometimes a day or two longer than would be for a transfer service doing it, but the transfer service and the crematoria can do those arranging as well.
Excellent. Oh, thank you. Do we have any more questions? It's still your chance to ask something. I think we have exhausted our question and answer period. Thank you so much, Dr. Huyer, and for a very extensive explanation. And okay, some resources. There's a Chief Coroner's office. It's a very long URL or address. So go to ontario.ca and look for Chief Coroner and you will find it. Bereavement Authority of Ontario, the BAO, is the licensing office. It also regulates funeral industry. That's very good to, and they know a lot about all kinds of details. So people often are looking for when or where was my grandfather buried or something like that. And then we have our own website, of course, is fams.ca. You find all kinds of information. And if you have any questions, remarks, or want to get any information, info@fams is our email address. And then our YouTube channel is at Fams Media 1957. 1957 was the year that we were established. And then we have Facebook on it's Fams Ontario. If you look for Fams Ontario, you will find us on Facebook. So thank you very much for being with us, and do spread the word and stay safe. And thank you for coming. And if the executive wants to stay behind, I will invite you to stay to talk about it. And for now, everybody, goodbye and thank you very much.
Thank you. Take care.
Thank you.
Thank you.
Bye.
Bye.